Well, thank you. I'm the last speaker, which is the one holding you up for dinner, but I hope we can keep your attention just a little bit longer. Thank you, Dr. Perry, for inviting me to have the opportunity to speak to this illustrious group of people here. These are my disclosures. Today I want to discuss a phenotypic spectrum of a rare childhood epilepsy associated with pathogenic variants in the gene SCN8A from the perspective of a parent-reported data in a longitudinal online registry. And I want to discuss genotype-phenotype correlations at the level of the entire gene and for individual recurrent variants, and discuss methods to classify patients based on clinical features and those associated with common recurrent variants. So the International SCN8A Registry, as Dr. Perry said, was something I started in about 2014, a couple years after we discovered the gene that caused my daughter's epilepsy. To me, she was just an N of 1, and a couple of years after we published, I started getting emails that other children were being diagnosed, and so I said, well, I don't know anything about the spectrum, if there is one, and I'm very curious, so we started the registry. And I designed the questionnaire initially around my daughter, but as new patients came in and I started to learn about the spectrum, we redesigned it a few times to try and capture the full spectrum. And even today, we're understanding that there are new patients coming that are expanding it slightly. It's tailored to SCN8A. It's tailored to the needs of families with affected individuals, and it includes things like their genetic reports, clinical features, developmental history, current and wean medication, brain scans. We get reports, EEG, EKG reports, et cetera. And we want to describe the full spectrum and the course of the disease. We want to describe genotype-phenotype correlations, identify patient subgroups within the spectrum, and aid in a clinical standard of care process that's ongoing right now with some of the speakers in this symposium, and aid in the design of trials. Ultimately, perhaps integrating with medical records, given that these are parent-reported data. And this shows some of the stakeholders. Families are critical. We get all the data from families, but the registry now is more than just a repository for information. It's a real tool that is helping to describe the natural history. We interact with clinicians, researchers, and pharma. So this just shows you the idea that it is a very wide spectrum. It ranges from no epilepsy and just behavioral or movement disorders to severe developmental epileptic encephalopathy, or DEE, with benign familial epilepsy and moderate to mild DEE as well. So this is a single etiology with a wide spectrum. It's kind of turning what we've heard tonight on its head, where you had multiple etiologies with a single sort of seizure presentation. Here we have a single etiology with multiple presentations. One gene, multiple presentations. So I'm kind of interested in if we can divide this spectrum up into subgroupings and use predictive modeling, machine learning, to classify patients into particular sub-discrete groups that may inform us on treatments that might differ for different patients. And can we explain the heterogeneity in the spectrum in terms of specific variants? I'm very curious about that. It's the question the parents ask: what does my child's variant mean for his or her future? So this is kind of the global picture. That I'm going to do an analysis tonight based on 381 individuals in the registry. You can see the current age distribution. It's really packed down towards the younger ages. The mode is 3 to 9 years, but we have a tail going out to 60 years old. The sex ratio is roughly equivalent. It's statistically slightly in favor of males, but biologically I don't think that means anything. And then you can see 90% of the folks in the registry have seizures, 10% do not. Well, it turns out that 10% is kind of a different subclass of individuals. And I'm going to basically try and convince you slightly tonight that it's really the loss of function patients. So we have both gain of function and loss of function variants within this gene. And loss of function variants, briefly, are variants that cause decreased sodium activity. So this is a voltage-gated sodium channel. The increased activity is due to gain of function variants, which cause persistent current and excitability and lead to seizures, where the loss of function, you can almost think of it as hypoexcitability, and there are two types of variants. There's truncating variants that basically eliminate the production of a protein So you have half the amount, it's haploinsufficiency basically, and missense variants that somehow prevent sodium from getting in the channel. And the channel is shown here in sort of its 3D structure. In order to do the test to determine for sure if this is loss or gain of function, these are in vitro tests, these are in heterologous cell systems. They're not laboratory tests, they're research tests, and they're not likely to be performed for individual patients in any time in the near future. So that begs the question, could we predict gain and loss of function, individuals that have gain and loss of function variants from their clinical features alone? And you can see here just a snapshot, there's almost all the gain of function variants. I shouldn't call them gain of function patients, they're patients with gain of function variants. And that almost all of them have seizures, whereas only a little over half of the loss of function individuals have seizures. And you can see the word cloud kind of just shows you some of the most prevalent difficulties these loss of function, patients with loss of function variants suffer. So what we did, I'll walk you through this a little bit. We did an exhaustive literature search for all the cases in the literature where patients with loss of function variants were known. Most of the time it was because there were in vitro testing, but not always. We found 71 cases, and then we constructed a predictive model based on a truth set, and we were very strict about the truth set. We only included individuals whose variants were shown to be loss of function by biophysical properties in vitro. And we eliminated individuals in this initial truth set that had other variants of uncertain significance and other genes that affected epilepsy in their genetic report. So it really broke down to about 45 loss of function variants, and then we matched that with much easier to find gain of function patients, 45 gain of function, whereby the same testing had been done. And then if you look at this table, this is showing you, these are Fisher test p-values for the difference between gain and loss. You can see, did they experience a seizure? 29 of the 45 loss of function did. The age at onset, 4.5 months for the gain and 40 months for the loss on average, with a large standard deviation. And then the seizure types, you can see the individuals with gain of function dominated with tonic-clonic focal and tonic seizures, whereas those with loss of function experienced absence and seizures. Intellectual disability was much more favored in the gain of function column, and the mutation type, of course, as I described before, missense variants were only case of variants in the gain, and so on and so forth. And if we looked at the phenotype as determined by a Danish group that's done many years of studies of their large cohort, you can see DEE 31 versus 3 in the loss of function group. And so on and so forth. And then those with generalized epilepsy and neurodevelopmental delay without epilepsy, primarily in the loss of function group. So what we did was we built this predictive model, we tested it and to determine its accuracy, and then we did categorization of the individuals. But you can see here in three-dimensional space, if I go back and start it again, you'll see it again. The gain of function patients in the 3D space are in the orange, and the loss of function mostly below the plane here in the blue, and you can see there's not much overlap at all. And so the model based on these features, the most features were a history of seizures, yes or no, age at onset, whether they were convulsive or focal, and myoclonic was included in convulsive versus absence, mild versus severe intellectual disability, DEE, and NDD without epilepsy. Those were the most important features that distinguish these in three-dimensional space. And then what we wanted to do was to make this more clinically relevant. So upon diagnosis, a clinician might see just many fewer of the features that we were initially using. And so if we broke it down to just 5 key features, I'll go back and start it one more time. You can see that we still had a good separation of gain of function in the orange strip here and the loss of function. And because we were only restricted to certain features that were variable among the loss of function, you can see the gain of function clustered pretty tightly. And then just to show you the full model, the 34 features, we had about a 99.8% predictive value and a 99.9% accuracy. And then for the 5-feature data set, 90% predictive value and 95.4% accurate. So even with 5 features, we feel like this is something that could be quite useful to clinicians. And just to mention that I'm not going to go through all the statistical machinations here, but we are also trying to use predictive modeling to see if there are distinct subcategories of those carrying gain-of-function variants. And what we found so far, we made a model that's 78% accurate. It's much harder to distinguish among just the gain-of-function, but you can see we have mild gain-of-function, moderate DEE, and severe. Over 50% of our population has severe DEE, and around 20% are loss of function. So now I want to just show you the gain of function individuals. I don't want to, I'm going to put aside the loss of function for now. You can see here we have age of onset, and you can see it's really, this is 0 to 3 months, 3 to 6 months, 6 to 9 months. And so, you know, these seizures are coming on in the first year of life, even in the first 6 months of life. And I will show you later that there's also a lot of neonatal onset. This is showing you the initial seizure type and the current seizure type as reported at the time that of inclusion. And it's dominated by generalized tonic-clonic seizures, but you also see we have focal, tonic, myoclonic, and infantile spasms in about 15% of our database. So infantile, and we're trying to figure out who those are that have infantile spasms that genetically might be quite interesting. And then absence and other types of seizures. Here, I'm showing you the current and the weaned medications. And you can see the asterisk represents the first prescribed. Most often it's levetiracetam, second phenobarbital, and then valproate. And the levetiracetam turns out to be a really lousy medication for SCN8A. That is often weaned, and we find that it makes things worse if it doesn't help at all. And, but still, we have about 1 in 10 that do okay on it. So it's still a mystery. We call it the Keppra conundrum. And over here you can see seizure freedom. And seizure freedom is, did you have a seizure in the last 6 months? And we find that those that say no tend to have very good periods of seizure freedom, although there are breakthroughs. And so really, you know, the definition of seizure freedom is really just this last 6 months. But again, I think it's a good indicator of how mild or how severe or intractable seizures are. So I think this is a pretty severe looking epilepsy, given that we only have, we have such a high intractability rate. This is showing you neurocognitive development. We follow Denver 2 skills, and you can see the older the individual is, this is the first, these are in months here, so this kind of goes for 5 years is what typically neurotypical development is tracking for these traits. But you can see as we go on, we are our individuals are falling further and further from neurotypical. You can see we measure fine, gross, adaptive language, and these are the average months delayed for each of these categories. And then, again, over 50% we consider to be severe in terms of not having gained 50% of these skills. It's not just a seizure disorder, it's comorbidities, and there are a lot of them. I'm just going to highlight a couple. I've put an asterisk by some of the most common ones, like low muscle tone and ataxia, intellectual disability, autistic features, and sleep difficulties. We know that sleep is a vicious cycle with seizures, and that's a big problem. And we have constipation, but we also have a lot of other very concerning things like cortical vision and blindness, and things that are not making it to the top 10, but are also very serious. A lot of gastrointestinal problems, a lot of G-tube and J-tube fed individuals. Just to do some overview correlations, those that are seizure-free tend to have a later onset, as has already been mentioned, and those that are seizure-free also tend to have a higher developmental quotient. Our developmental quotient is derived entirely based on the number of developmental skills acquired by these individuals. So seizure freedom and age at onset is something I'm going to show you over and over again. Now, the next step here is to try and see if there's any genotype-phenotype correlation. So what you're looking at is the neuronal membrane here, and the NAV 1.6 channels is seen by the 1980 amino acids encoded by the SCN8A gene, starting here, and there's 4 domains, and there's 6 segments within each domain. And what I'm showing here with the yellow stars and orange stars are individuals with epilepsy, and then the blue dots are neurotypical individuals. So we can do odds ratios tests to see where the hotspots are, but if you squint your eyes, you can see where these are clustering. But there are some variants that are very common, like 850 and over almost 30 individuals, 1475, 1617, and then 1877, and then 1872 is the most frequent recurrent variant. It's over 50 individuals, and there are 2 amino acids at 1872, tryptophan and glutamine, or W and Q, and we can actually split those out to see if they're different. So the next thing I want to show you is correlations we've done with each of the variants shown here, the age at onset and the percent seizure freedom, and it's quite interesting that you see this strong correlation. These variants do have characteristics that are fairly reproducible in a sense, and you've got the more early onset variants here, 850 and 1872W. Q does separate out to be a little bit milder, and milder in the sense of later onset age and more seizure freedom reported, and then 2 that are quite mild, 1877 and 1475, in the sense of being later onset and more seizure freedom and higher developmental quotient. So developmental quotient and seizure freedom, again, correlating very nicely with age and onset in a positive manner. And what's shown here is the negative correlation. So the early onset seizures have a higher number of drugs that have been tried and failed, as well as a higher number of drugs that are currently maintaining treating seizures. And then as the older onset patients have tried fewer, failed fewer, and are maintained on fewer. And this is just showing you, again, the number of drugs, and you can see very easily the milder variant, or the more severe variants, you have a much bigger failure rate. I haven't calculated intractability in the way that it was just defined, but I'm going to do that at some point when I get back home. And then the milder variants, you can see here, failed fewer, maintained on fewer. Quite interestingly, we can use our predictive model to say, for each of the individuals with these variants, if they fall into the mild, moderate, and severe class. And you can see the more severe variants here, with the earlier onset, you see more severity as shown by the cobalt blue. And in the milder variants, you see they're more in the mild and moderate category. So that's quite interesting as well. We're also looking at comorbidities by variant. So these are the categories, color-coded, I showed you before on the human body. And you can, we're starting this work, and for instance, we see 850 as a positive hit with cortical vision impairment. Most of our patients with 850 have both infantile spasms and cortical vision impairment. And for the milder variants, we're seeing hits in the behavioral aspect. So behavioral features like autism or movement disorder type things, those are more common in the milder variants. The issues are not necessarily seizure control. They kind of move on to the more developmental behavioral issues. There are age-associated increases in differences. So I'm dividing the patients now into less than 5 and greater than 10 years and looking at the middle. And then I just did some statistics on the two extremes, and you can see there's an increase in number of seizure types with the middle group kind of intermediate. The percent that are reported to be developmentally delayed is much higher for the older group, with the intermediate group closer to the younger group. And then the number of wean drugs is high for both the older and the middle group. And what I'm thinking is this could be an indication, a glimpse of the natural progression of the disease. As individuals age, they do get more seizure types, more difficult to control, et cetera, and need more drugs. However, something very important here is we only discovered the gene 10 years ago, and patients that are older than 10 knew nothing of this gene and that they had this gene. And so I think that there's an onset diagnosis gap that has to be considered. And you can really see that the difference in months between onset of seizures and diagnosis as SCN8A increases dramatically for the older group. And it's almost a stepwise pattern. And I think we're going to have to separate that kind of factor out if we really want to see disease progression. And we're going to have to look at more longitudinal data using every individual as its own control to really get at that problem. So about 10% of our, 10 or 12% of the individuals in our cohort are on monotherapy. It's not much, but you can see that the medications that are dominant in, obviously it's a voltage-gated sodium channel, so sodium channel blockers are the most used drugs in monotherapy. You see clobazam popping up a little bit, but oxcarbazepine is the most commonly used drug in general and in the cases of monotherapy. If we look at individuals on 2 drugs, it's not necessarily controlled very well, but you get a hint at what kinds of things that 2 people on 2 drugs do is they add valproate, or valproate, I don't know which comes first, but valproate is in combination with a sodium channel blocker generally, and then you see a little bit of lacosamide coming up, and many, many times it's another sodium channel blocker. But for dual therapy, 2 sodium channel blockers and valproate plus a sodium channel blocker are most common. Now, is that the best therapy? We don't know. It's just what's most commonly used currently. So what's the impact on care and practice? Summarizing, predictive modeling classifies patients into loss and gain of function. We've made a lot of progress toward subdividing the gain of function into distinct severity groups. Patients with milder variants have later age at onset, tend to have a higher rate of seizure freedom and higher developmental quotient, and require fewer ASMs to manage their seizures. Genotype-phenotype correlations offer opportunities for investigations into cause and effects relationships and precision medicine approaches to treatment. And patterns of disease progression offer a baseline for comparisons of outcomes in clinical trials. And I think that's the next step for us, is to get at that more, natural progression or natural history. Great team of people working, both at the University of Arizona and people like Dr. Schreiber, who joins us from Children's National, statisticians, and our International SCNA Alliance team is fantastic. We have online network meetings with families weekly. So I'm in touch with a lot of families, and we advise them on the science, and we hear from them on their concerns, and it really helps us understand this disease from all points of view. We have family members who are volunteering and helping us, and we've also worked with Combined Brain in some of this work. So I thank you for your attention.